I'd like to begin by thanking Business World, Mr. Narula Smriti, for giving this opportunity. I was asked to speak something along the lines from technology in terms of cancer management and prevention. So we decided to talk today in this session about proton therapy in the management of cancer, in particular about the impact of technology, primarily because now we have this facility in the country, and I'll share what is the rationale of this therapy and also share with our preliminary experience from our country. As you may have heard from morning by various speakers, that although there continues to be lots of challenges in cancer with its presentation and so on and so forth, but also we are realizing that many of them can actually cure cancer, be cured, and it's been estimated that about 50%, if not more, could survive for more than 10 years. It is, however, tempered with the fact that although they get cured, many of these patients do have some issues long-term, either primarily because of the disease per se, but also disconcertingly because of the treatment. One of the very famous studies came from the US, what is called the Childhood Cancer Survivor Study. And now this has been expanded to 20,000 odd patients, because childhood cancers have very high level of surviving cancer, more than 70 to 80%. So while they were surviving very well, but a significant proportion of them, unfortunately, had a chronic medical issue, and about a quarter, in fact, had severe or life-threatening issue, which impacted on their education, their employment, their day-to-day activities of daily living, and so on and so forth. Now, how to address it? We have seen already enhanced surgical skill and technology. You just heard a fascinating talk on molecular signature-driven personalized therapy, whether it is systemic therapies, targeted therapy, or immunotherapy, high precision radiation, particularly in terms of protons, which I'll be speaking in the next few minutes. And ultimately, the aim is to achieve this fine optimal balance between achieving long-term survival and cure, which is, of course, absolutely paramount for our cancer patients, but also equally, if not more important, to ensure they lead very high quality of life into their day-to-day activities, what's called. So it's not only the cure, but it's also the quality of cure. Among the various three principal modalities of cancer treatment being surgery, systemic therapy, and radiation. So radiation therapy was started about 120, 130 years old. It was very preliminary and very basic and archaic that time. Over a period of time, we have seen the development of radiation from relatively very simple technology of orthovoltage therapy to megavoltage therapy. In about 20, 25 years ago, there was an era of conformal therapy. And now the current standard of treatment is anywhere between stereotactic radiotherapy, intensity modulated radiotherapy, guided by image guidance, where the delivery of radiation is done under imaging parameters, such that you plan very high precision form of radiation, but we also image on a daily basis whether this has been delivered precisely where you want to target the tumor. And then I will, of course, talk about the current, which is taken many people by a lot of enthusiasm, is the current interest in proton therapy or particle beam therapy. India, fortunately, has adopted new radiation technology readily over the years. And because the session is on technology, and I'm just talking for whether it is gamma knife, whether it is local radiation therapy called brachytherapy, stereotactic radiation, cyber knife, tomotherapy, we were among the first ones to adopt as soon as it came in other parts of the world. And of course, now the proton therapy as well. The concept of proton therapy, of course, is not very new. It was many years ago. Robert Wilson was the first one to demonstrate to us that there could be a potential benefit of proton therapy. And this is typically seen in this very famous cartoon that we show, that the conventional radiation that we use on a daily basis in routine practice, whether it is cobalt therapy machines or the linear accelerators, which is currently the standard of care, use conventional X-rays, which are electromagnetic radiation. They travel with the speed of the light. They have a certain entrance dose. They treat a certain amount of normal tissue, and then there is a significant exit dose. Proton therapy would have, it's a positive charge, a light ion, as compared to neutral charge in a conventional X-ray. They may have a little bit of an entrance dose, but because of their unique physical properties, they dissipate all the ionizing radiation is at the peak, at the end of the beam, what we call, and that is called a Bragg peak. And it was a Nobel Prize was given to William Bragg when he discovered that. And after that, we have this dramatic fall off of the dose, where literally the exit dose is practically nil. So as compared to the conventional X-rays, where the radiation will be given, they will treat a certain amount of tissue, but there will be invariably some exit and collateral damage to the surrounding tissues. While the proton therapy, while there will be entrance dose also will be relatively less, but then if you can define the target near the Bragg peak, they will receive very high dose of radiation, but practically there is no dose whatsoever beyond it. So this was an amazing physical technological prowess which the proton therapy world had. Although it was a relatively old concept, but it was limited primarily to research facilities, which was very, very tedious and very technological demanding. And you couldn't really do it except in physics laboratories or some centers. Although Loma Linda in Berkeley in California did start a small proton unit in 1990, although some of the others were also in Mass General and Loma Linda, as I mentioned, in the US. The erstwhile technology, unfortunately, was very cumbersome. It was called passive scanning. If I have to explain, that was like a torch. The beam used to go like a torch, but the tumors are not like a round, tumors are different shapes. So while this gave a certain amount of radiation dose, was very precise, but the rest of the tissue to spare, we had to use additional material, for example, these collimators and apertures, which was very time consuming, too much hardware. There was a neutron contamination. So basically, it was very, very difficult to accomplish in a hospital-based system. Although there was a clear-cut dosimetric advantage. If you look at this conventional X-rays to treat this tumor here, the red part being the tumor, as the technology evolved, it became more and more conformal, shaping around the tumor, but giving some dose to the surrounding structures. And proton, if you see, is beautifully conforming to the shape of the tumor and completely sparing the rest of the normal tissue. And that was the advantage. The significant jump in technology took place about 10 to 15 years ago, what is called evolution of modern contemporary proton beam therapy. And therefore, we always say there is a proton and there is a proton. So proton beam therapy in the current era does not use like a big torch-like material. It uses a small pencil beam, like a laser pointer. And instead of the whole target, it slices the target into several slices, such that, and the energy also has increased from 70 MeV to 230 MeV. We use sophisticated physics algorithms like Monte Carlo algorithms, such that you can literally, what we call, you can slice the tumor in different slices, and this pinpoint goes spot by spot, line by line, layer by layer. So you treat several layers in few minutes, such that you achieve ultra high precision conformal, what is called literally dose painting around the target. And because there is no exit dose, so physical and biological advantages there, it will just remain where the tumor is. There'll be a little bit of entrance dose, but there'll be no exit dose, and you can shape the target very well. The advantage is that you don't have the passive scatter, you don't have any neutron contamination, you don't have any extra material that you have to put in the gantries like the collimators and the brass material. It's just a small pencil beam can do the job. Therefore, there has been a renaissance in the application of this technology. In our country, you have seen these figures since morning, the incidence of cancers and how many people do need radiation per year. So Apollo hospitals were among the first ones in the entire region, not only in the South Asia. It's still in Chennai is the only proton therapy facility in the country, and along the entire Southeast Asia, including Africa. The nearest one, and there are 3 or 4 coming up in the rest part of the world, and the nearest ones are in Japan and Korea. The American Society of Radiation Oncology have this group model policies based on insurance and the level of evidence, and has been seen in that many sites, whether these are base of the skull tumors, very challenging cancer sites where the regular radiation cannot do the job. In liver cancers, we just heard a very good talk from Dr. Soin from liver cancers, spinal tumors. all childhood cancer tumors, because children, the cure rates are very high. It is very critical to spare every single centimeter of the normal tissue, whether it's the brain or the other parts of the body, because you want to preserve their normal function when they grow up. So development point of view, very, very important. So central nervous system tumors, head and neck cancer, sinuses, retroperitoneal tumors, and whenever you have to have re-radiation. That doesn't mean every single case should have proton. It has been estimated that in the next 10 to 15 years, while the evidence accumulates, about 20-25% of the patients would be eligible for proton therapy. And also, group 2 indications are where there is ongoing research in other forms of head and neck cancers, for lung cancer, esophagus cancers, abdominal malignancies, pelvic malignancies, and fascinating data coming in prostate cancers and breast cancer. As I mentioned, the work started, it takes about 5 to 6 years, not easy to design a proton facility, was started to the Atomic Energy Regulatory Board. For them also, it was relatively new because it was the first time the country had this kind of facility available. It took several years. These are just some of the timeline and milestones. Eventually, Vice President of India, along with our other senior leadership, we could manage to get the clearance from the AERB in December 2018. And 2nd January 2019, we did the first ever patient. We have published 2 very important physics-related papers, basically to characterize the evaluation of the first proton therapy facility in our country. We also have other aids.
Otherwise, at home or maybe during the weekend, Crocin is something that can be prepared.
You may probably have to mute.
Salman, can we mute? Yeah, thank you.
So there are other technical details to just make advantage of the technology. So while we were among the first ones, of course, all over the country, but we also, because there are only about 120 to 130 proton facilities in the world, although every year we are adding about 10 to 20. There will be a very soon another facility in our country, maybe in the next few months operation as well. Fortunately, we have catered to people from all over the world, from all over the continents, including one patient from South America who came for the brain tumor a few months ago. Our first series of proton therapy was published 2 years ago in a very important journal, which basically characterized that it can be implemented this was primarily for children and young adults who are a prime candidates for proton beam therapy. And we have also justified in a recent article in, again, JCO's Global Oncology, that why it is needed in lower middle income countries as well, because of the cost and investment. So there's always this debate whether we should use it in our countries as well. We have already crossed 700 patients in the last 3 years or so. We treat close to anywhere between 35 to 45 patients per day, starting at 7:30 till 10:30. It is a very rigorously calculated protocol that we have. These are the case mix, from brain tumors to prostate to head and neck, gynecological cancers, breast cancer. A good proportion of the patients belong to the pediatric population. And the youngest child we have treated is 10 months, and the oldest person we have treated is 88 years. We did have some challenge on COVID-19, but we managed to get a green zone for the proton therapy patients, so they did not have any much problems in spite of the pandemic. Some of the examples I like to give, this is a very common pediatric brain tumor, craniopharyngioma, has a very good survival. But the important part is that you have to avoid very important structures when they grow, particularly the memory area. And the memory area is done by what is called hippocampus. So you could significantly spare the hippocampi, such that not only is the tumor control and the cure rate is more than 95%, more than 10-year cure rates are available so far. And so far, whatever we have done, although the relative follow-up is only about 2 years, but all the children are doing extremely well, and they are also maintaining their cognition and memory, which is an important endpoint for these type of brain tumors. One of the very complex forms of radiation is called CSI, called craniospinal radiation, where the entire brain and the entire spine has to be treated. In the conventional radiation, when you treat it, you swathe literally the whole body with low dose radiation. Here, what happens with the proton therapy, because there is no exit dose, you can completely spare the thyroid, the liver, the lungs, the kidney, the other abdominal organs, and the gonads, which is again very important in children and young adults. So far, again, very encouraging data. This paper is actually under review at the moment, is likely to get published in, again, a very major important international journal. One of the case examples is very interesting. It's called intracranial germ cell tumors. This is an example with permission of this child who received chemotherapy and went on to have proton therapy. One of the challenges for these children are, although they get cured, they have significant issues in memory and other cognitive and developmental areas because of the collateral damage to the brain, as I was just mentioning. This child really surpassed our expectations. Not only she became very tall because of the endocrine deficits were not there, but she went on to score exceedingly high in her 12th exam. And we always joke, how did you miss those 7 marks? And this was, again, a very encouraging sign for this particular patient. One of the important issues in childhood cancers in general is, as I mentioned, the excess dose, which can actually reduce significant doses from the proton therapy as compared to conventional, to the cochlea, to the heart. Significant reduction of second cancers. About 2% to 20% of the cancer survivors unfortunately develop second cancers in future, partly genetic, partly because of radiation and chemotherapy. If at all there is one indication where significant reduction of second cancer instances, it is because of the proton as compared to conventional radiation. And there is tons of data available out there in the literature to support this plan. Finally, 2 or 3 slides on other sites. My colleague, Dr. Nangia, is responsible for head and neck cancer management team. I see Dr. Deepak Sareen talking after that. He will appreciate that oral cavity actually is one of the commonest cancers in our country. And what we have demonstrated is both in young patients, but also increasing in elderly patients, where the tolerance of radiation chemotherapy, either upfront or post-operative, is always a challenge. Because you can limit the dose to the surrounding normal oral structures, they are able to tolerate the treatment extremely well without any interruption, without any break, without any other issues that is otherwise a problem in head and neck cancer. So we have a very interesting experience so far in head and neck cancer treatment. And for the elderly people, we are running a prospective study called a senior study for geriatric patient population, because this patient population always has issues. In the thorax, because the lung moves, so becomes more difficult. So we are doing, again, a very technological demanding proton therapy for moving targets as part of a protocol called PROMO, both in the free breathing and breath hold protocol. It's too technical to explain to this in this audience, but suffice to say that, again, after several technological innovations, we have now launched proton therapy for moving targets as well. Prostate cancer becoming very common. Dr. Srinivas is the expert with me here. Again, part of a study where we are able to reduce the doses of radiation significantly to the rectum and the bladder, which otherwise is an issue with conventional radiation therapy. And again, very encouraging data for prostate cancers. And so is in GI cancers, whether it is to bridge therapy before transplant or per primum in the liver cancers, challenging esophagus and pancreatic cancers. And again, this is an encouraging endpoint. One of the most encouraging parts throughout the world is an increasing focus on left-sided breast cancer, because when you give conventional radiation, although they can cure many of these breast cancers that preserve the breast also, unfortunately, there's a significant dose to the heart. And with the proton therapy, you can, APCC, our Proton Cancer Center, Apollo, you can literally reduce the doses to the heart and all the major vessels, literally to really, really very low levels. And this, again, is a part of ongoing study where we'll collect the data meticulously and try to come up with the guidelines for future. Finally, although there is an investment in the beginning, there is always this debate throughout the world. Business World is a perfect and ideal platform to explain about this. There are several economic models, for example, Marco model, where they see the initial investment, but also see the survivorship. What is the probability of the patient surviving the cancer, but also returning to work? What is his cognitive parameters? What is his growth parameters? Are there any side effects of radiation? It has been estimated that while the investment is more, whosoever invests, whether it is government, private, whosoever, eventually it becomes actually cost effective in childhood cancers, in breast cancer, in some of the lung cancers, and some of the head and neck cancers. And more data is being accumulated for this. As I mentioned, we are very conscious of this technology, and so putting up a lot of research studies such that precious data is collected prospectively and shared with the rest of the world. We recently did an educational exercise of proton practicum, which we do every year. 700 participants from 21 countries participated in it, and we will do every May on this technology. So this was just to give you a snapshot of the technological advances in radiation therapy, in particular proton therapy, and how it is impacting the cancer survival and also importantly, cancer survivorship. With that, I thank you very much for your attention.